Hi everyone, I welcome you all for this nursing wisdom channel. Today we are going to see about Oligo Hydromnios. The word Oligo Hydromnios meaning oligo means little or less. Hydromnios means amniotic fluid. So less or little amount of amniotic fluid is called Oligo Hydromnios. Definition: it is an extremely rare condition where the liquor amni is deficient in amount to the extent of less than 200 ml at a time. That means during time amniotic fluid amount less than 200 ml is called oligohydromnios. Sonographically, it is defined when the maximum vertical pool of liquor is less than 2 cm or when amniotic fluid index is less than 5 cm. So from this definition we understood oligohydromnios means amniotic fluid volume is less than 200 ml at a time, amniotic fluid volume less than 5th percentile for gestational age, amniotic fluid index less than 5 cm, single vertical pocket less than 2 cm. So we will see one by one what is normal amount of amniotic fluid index and single vertical pocket. Normal volume of amniotic fluid. It varies with duration of pregnancy. At 12 weeks of gestation, amniotic fluid amount will be 50 ml. At 24 weeks of gestation, amniotic fluid amount will be 500 ml. At 36 weeks of gestation, amniotic fluid amount will be 1000 ml. Thereafter, amniotic fluid amount started to decreases. At a time, the normal range of amniotic fluid in single tone of pregnancy is 500 to 1500 ml. Amniotic fluid volume less than 5th percentile for gestational age. This graph depicts the normal amount amniotic fluid volume for gestational age. Here you can see below 5th percentile means amniotic fluid amount fall below 500 ml and it indicates oligohydromnios. An amniotic fluid index. Amniotic fluid index measured by using transabdominal ultrasound. The amniotic fluid index is measured by dividing the uterus into 4 quadrants. The linea nigra is used to divide the uterus into right and left halves. The umbilicus serves as the dividing point for the upper and lower halves. The transducer is kept parallel to patient's longitudinal axis and perpendicular to the floor. Then the sonographer measures the amniotic fluid in each of the 4 quadrants of the abdomen and add the values of 4 quadrants together. Normal amniotic fluid index values ranges from 5 to 25 cm. Less than 5 cm is indicative of oligohydromnios. More than 25 cm is indicative of polyhydramnios. The deepest vertical pocket. To calculate a single deepest pocket, the sonographer scans each of the 4 quadrants of the abdomen looking for the deepest pocket of the amniotic fluid that does not include any fetal body parts or an umbilical cord. The usually accepted values are 2 to 8 cm is normal, less than 2 cm indicative of oligohydromnios, more than 8 cm indicative of polyhydramnios. Incidence: oligohydromnios affects about 4% of people who are pregnant. It is most common in the last 3 months of pregnancy. This rate rises to about 12% in people who are past their due date because amniotic fluid level decreases after 40 weeks of pregnancy. Amniotic fluid. Amniotic fluid is necessary to allow for normal fetal movement, lung development and cushioning from uterine compression. The amount of amniotic fluid is based on how much fluid is produced and how much is removed from the amniotic sac. In the first trimester, the main sources of amniotic fluid are fetal lung secretions, transportation of maternal plasma across the fetal membranes, and the surface of the placenta. By the second trimester, the fetal kidneys start to produce urine, which becomes the main source of the amniotic fluid for the remainder of the pregnancy. So, large proportion of amniotic fluid is made up of fetal urine, 500 to 1200 ml of urine at a time. So, to maintain normal range of amniotic fluid, fetal urine is very important. Etiology of Oligo Hydromnios. The exact cause is not known, but some maternal, fetal, and placental factors may lead to Oligo Hydromnios. Maternal factors includes maternal conditions such as preeclampsia, chronic hypertension, collagen vascular disease, nephropathy, thrombophilia. Medications such as angiotensin converting enzyme inhibitors such as lisinopril, prostaglandin synthesis inhibitors such as NSAIDs, anti-inflammatory steroids, trastuzumab, maternal dehydration, and infections such as torch infection that includes toxoplasmosis, rubella, herpes simplex virus, cytomegalovirus, syphilis, and paravirus B19. Fetal factors includes chromosomal abnormalities such as Down syndrome, triploid pregnancy, congenital abnormalities such as renal agenesis, cystic renal disease, posterior urethral valves or urethral atresia, intrauterine demise, post-term pregnancy, rupture of membranes, intrauterine growth restriction, and amnion nodosum. Placental factors includes placental abruption, twin transfusion, placental thrombosis, or infection. We will see one by one. Maternal factors. Maternal conditions such as preeclampsia, chronic hypertension, collagen vascular disease, nephropathy, thrombophilia cause uteroplacental insufficiency that decrease blood supply to fetus kidney that will cause impaired urine production, which leads to reduced amniotic fluid and cause oligohydramnios. Drugs. If the mother is taking medication such as angiotensin converting enzyme inhibitors like lisinopril, prostaglandin synthesis inhibitors like NSAIDs, anti-inflammatory steroids. Next, trastuzumab. It is humanized monoclonal antibody used in treating breast cancer. This drug will cause decreased blood flow to the fetus kidneys. That will cause decreased blood supply to fetal kidneys and leads to decreased amount of urine production. That will reduce amniotic fluid amount and leads to oligohydramnios. Maternal dehydration. Maternal dehydration, especially in the hotter summer months, will affect fetoplacental circulation and will decrease blood supply to fetus kidney. That will lead to decreased amniotic fluid and will cause oligohydramnios. Intrauterine infection. Intrauterine infection, torch infection that includes toxoplasmosis, rubella, herpes simplex virus, cytomegalovirus, syphilis, and paravirus B19. This infection will cause PROM, that means premature rupture of membrane, that leads to liquor amni to escape and cause oligohydramnios. Fetal factors. First one is congenital anomalies. Congenital anomalies such as renal agenesis, that means absence of one or both kidneys production. Cystic renal disease means cyst present in kidneys, and posterior urethral valves and urethral atresia. Urethral atresia means failure to develop an opening in the urethra. In renal agenesis and cystic renal disease, there is no urine production, and in posterior urethral valves and urethral atresia, urine will produce, but this condition will obstruct the urine flow. That will lead to reduced amount of amniotic fluid and cause Oligo Hydromnios. Intrauterine demise. Intrauterine fetal demise, also called IUFD or stillbirth, occurs when a child dies in the womb at or after the 20th week of pregnancy. In this condition, fetus already died, so no urine production and will cause Oligo Hydromnios. Post-maturity. Post-maturity means more than 42 weeks of gestational weeks. Slight decline in hourly fetal urine production occur after 40 weeks. As the pregnancy continues post-term, further reduction occurs to the extent of about 200 ml at 43 weeks. So post-term will cause Oligo Hydromnios. Amnion nodosum. Amnion nodosum means nodules found on the amnion that will cause failure of secretion by the cells of the amnion and cause Oligo Hydromnios. Next, placental factors. First one is placental abruption. Women with chronic abruption experience relatively light to chronic intermittent bleeding and develop ischemic placental disease that will cause placental insufficiency and leads to decreased blood supply to fetus and cause decreased urine output that will cause decreased amniotic fluid and leads to oligohydramnios. Twin transfusion. With the twin-to-twin transfusion syndrome, which occurs in 10 to 15% of monochronic twin pregnancies, there is an imbalance in blood flow due to placental vessel connections. One twin, called the donor twin, gives too much blood to the recipient twin. When a fetus is anemic or doesn't have enough blood and oxygen, it tries to use what it has most efficiently. This is accomplished by emphasizing the blood flow to the most important organs, the brain and the heart, and shutting down less vital organs, such as the kidneys. So donor fetus get little blood supply to its kidney and produce less urine. That will reduce amniotic fluid amount and cause oligohydramnios. Next, placental thrombosis or infection. Placental thrombosis or infection will cause placental insufficiency that will decrease blood supply to fetus. So there will be decreased urine production and reduced amniotic fluid amount and leads to oligohydramnios. Next one is chromosomal abnormalities such as triploid pregnancies and Down syndrome cause placental abnormalities. Placenta is enlarged and may have cyst within, or in some cases the placenta may be unusually small, having stopped to grow. That will cause placental insufficiency and inadequate blood supply to fetus, leads to reduced renal perfusion and cause decreased urine output, leads to reduction in amniotic fluid and cause oligohydramnios. Next is rupture of membrane. Rupture of membrane cause escape of amniotic fluid, leads to reduction in amniotic fluid and cause oligohydramnios. Next one is intrauterine growth restriction. IUGR associated with placental insufficiency that will cause inadequate blood supply to fetus and leads to reduced renal perfusion and urine output decrease and cause oligohydramnios. Next, clinical manifestation. Uterine size is much smaller than the period of amenorrhea, less fetal movements. The uterus is full of fetus because scanty liquor and prominence of fetal spots present. Malpresentation breach is common. Evidence of intrauterine growth retardation of the fetus, not gaining enough weight, leaking fluid from vagina in case of PROM. Diagnosis. Confirmation is made with sonographic diagnosis. In case of oligohydramnios, the amniotic fluid volume less than 200 ml at a time, amniotic fluid volume less than 5th percentile for gestational age, Amniotic fluid index less than 5 centimeters. Single vertical pocket less than 2 centimeters. Retaking a maternal and family history and performing a physical exam can point to maternal conditions or medication that might be causing the oligohydromnios. Premature rupture of membranes or pre-labor rupture of membranes is ruled out with a nitроgen test, evidence of firming or evidence pooling of liquid in the cervix. Sonographic evaluation of the fetus is done to identify fetal anomalies, aneuploidy, fetal growth restriction, or placental abnormalities. Genetic testing can be useful if fetal anomalies are documented on imaging. An elevated maternal serum alpha-fetoprotein can indicate leaking amniotic fluid due to damage to fetal membranes or the placenta. This is associated with a poor prognosis. A maternal blood test or amniotic fluid test can be performed if suspicion of a torch infection is high. Treatment: amnio infusion. There is no way to permanently increase the volume of amniotic fluid, but it can be temporarily increased. One way to achieve this is through an amnio infusion, which is the insertion of 200 ml of saline or ringer lactated solution into the amniotic sac. Amnio infusion is also facilitated to allow for a complete anatomy scan of the fetus on ultrasound and external cephalic version. Amnio infusion can be used during labor to prevent umbilical cord compression. Next, adequate hydration. 1 to 2 liters of oral hydration can temporarily increase amniotic fluid in dehydrated patients with isolated oligohydromnios. Prenatal care. Patients who are preterm or managed in the outpatient setting with weekly or bi-weekly testing to monitor for accurate fetal growth and decrease chances of unexpected fetal death. This includes a weekly non-stress test and single deepest pocket assessment. Sonographic fetal growth exams may also be indicated. Timing of delivery. Idiopathic, uncomplicated and persistent oligohydromnios can be delivered at 36.0 by 7 weeks to 37.6 by 7 weeks of gestation or at diagnosis if diagnosis is later. Premature rupture of the membrane is common. Labor may be protracted and the contractions are more painful due to inadequate amniotic fluid. Vaginal delivery is favored. In case of fetal distress occurs or unfavored condition, delivered by LSS. Next is complication. Fetal complication. First one is abortion. If oligohydromnios occur in first trimester or early part of second trimester occur, that leads to miscarriage. Deformity. Deformity is due to intra-amniotic adhesions or due to compression. Intra-amniotic adhesions, otherwise called as amniotic band syndrome, can occur when the inner layer of the placenta, called the amnion, is damaged during pregnancy. If this happens, thin strands of tissue, amniotic bands, form inside the amnion. These fiber-like bands tangle around the developing fetus, restricting blood flow, thus affecting the growth of certain body parts. This can cause congenital deformities of limbs. In some cases, strands can tangle so tightly around the limbs of a fetus that they amputate them. Compression due to less amniotic fluid, maternal structure compress the fetus and umbilical cord. The deformities include alteration in shape of the skull. Wry neck, otherwise called as torticollis, is a painful twisted and tilted neck. Next is club foot, is a deformity in which an infant's foot is turned inward. Next is amputation of the limb. Amputation is the loss or removal of a body part such as a finger, toe, hand, foot, arm or leg. Fetal pulmonary hypoplasia. Pulmonary hypoplasia is a condition in which the lungs are abnormally small and do not have enough tissue and blood flow to allow the baby to breathe on his or her own. This is because amniotic fluid plays an essential role in lung development. The unborn baby breathes the fluid into the lungs, where it pushes open the air sacs and stimulates them to grow. During the middle of the second trimester, 16 to 24 weeks, the baby undergoes an important phase of lung development. If the amniotic fluid is very low during this period, the baby may not create enough lung tissue and may have trouble breathing at delivery. Cord compression. One of main function of amniotic fluid is to cushion the baby's umbilical cord. Low level of amniotic fluid therefore raise the risk of umbilical cord compression, which obstruct the blood flow and oxygen and nutrients to the baby. High fetal mortality. The fetal mortality occur mainly due to lung hypoplasia and cord compression. Maternal complication. Prolonged labor due to inertia, increased operative interference due to malpresentation. The sum effect may lead to increased maternal morbidity. I hope you got clear about oligohydromnios. Thanks for watching.